So, hello and good evening, everyone. Welcome to our 57th Blue Hills virtual seminar. Blue Hills virtual seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Hills Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Dr. Hewan, a general physician and first aid trainer from Blue Hills, Ethiopia. Today, it's a pleasure to have Dr. Hewan Aklilu here with us to present on the changes of quality improvement. So those of you who don't know Dr. Hewan Aklilu is the Quality and Planning, Monitoring and Evaluation Officer, as well as a quality trainer at Liana Healthcare at Yanet Hospital at Hawassa. Dr. Hewan has over 5 years of experience as a quality officer in multiple governmental hospitals.
Thank you so much. Already introduced, I am Hewan, a medical director and a medical doctor in working on quality for about 6 years and currently working on a private hospital as an additional duties. On today's session, we will see the changes for quality improvement. I think when you see the topic, everyone has a question because it's a bit different from the other topics, but not more different than the others. It just includes, if you know the detail, the quality improvement training module of our government by the Ministry of, prepared by the Ministry of Health. Module 4 and 6 will be covered within these topics. It's not fast, but more focus on how to generate changes that can result in quality improvement. The main gaps in healthcare are also generating change. The processes, the root cause analysis, problem identifications, and other things are more or less easy because on our day-to-day activities, we encounter problems, we encounter gaps, we identify gaps on our performance evaluations, and also we daily receive from our customers comments to improve and everything. Since these things are common, identifying problems and root causes, my today's focus is how to generate changes that can result in an improvement. And as you know, as you see this quote in my first page, the quality of your thinking determines the quality of your life is my beginning message. So to start with my session, as an introduction, we will discuss on the objectives of the presentation, then introduction part. I will not go through the introduction part detail because with many sessions you have already discussed the idea of what quality is and how it's interpreted, but as an introduction we will discuss on the quality definitions and especially what change is, and we will define what change is. And then we will see on the improvement concepts, what improvement is, what change concepts are, and how to generate these change concepts, what to use, what knowledge are required, what the different types of changes we will cover with this idea, and on the next, how to generate changes using our thinkings. There are different types of thinking, lateral thinking, logical thinking. We'll discuss it in detail. We will look at this detailed change generation tools, and we will summarize and finalize our session. So at the end of this session, I want all participants to be able to know the science of improvement, what improvement is, and what the science of improvement says, and what things are considered and what focuses are what focus on science of improvement, and then we will be able to describe the types of knowledge to develop an effective change. Effective change means a change that can make a result and that can make a continual improvement. So I need you all to note these changes, and I want you all to have, at the end of this session, to have that creativity of generating new ideas, new changes, new change concepts for a problem raised in our facilities, in our organizations, and this will also help us in our day-to-day life. Creativity method of generating new ideas, then logical, how we use a logical thinking method, and using the logical thinking method, how to apply it in producing change that can make a result. Then finally, I want the participants to be able to differentiate between what are fundamental changes and what are reactive changes. So note this, and I think we will entertain a question after this one. So as an introduction, quality is the standard of excellency of something or someone or a facility or a section of a facility or a part of the system. Often we usually expect the word quality with high standard. Quality definition of quality differs between people's or between one person and the other person. One thing which is quality or high standard for someone will be low standard or low quality for others, but especially in healthcare, there are stated standards, stated policies, stated procedures. So attaining that stated procedures or working with that standard procedures stated or set in one organization and adhering to that standards to bring excellency in every part of our workers, especially it will result in the output of our service. Excellency will be notified by our service. So this standardization and bringing excellency of something or what we work is defined as quality. And the other definition is the extent of resemblance between the purpose of healthcare and the truly granted care. We provide a care usually as Donna Bidian explained about quality. It's not, healthcare is not like it's not like as a product, selling products or other things like cosmetics or others. We are working on a human being, so we need to have the eagerness in the love of our work and the love of our patient care. So if we resemblance between the purpose of health care and the truly granted care, he defined as it is quality. So when we come to the change definition, you all know change is when something is different from the previous one, we call it change, or when something is altered and or modified by something and produced which was not present, we call it a change, and replace with something else. We have something on hand, or we have our outpatient service waiting time. It could be waiting time, it could be our queue management, it could be the system, or when we take our chronic follow-up cases, the outcome, the non-communicable disease. When we work on non-communicable disease, it could be the control rates, everything in healthcare facilities. When they have a gap, and when we replace this gap with a special thing, a special kind of some kind of newer or better care, better way of providing service, better way of communicating clients, better way of receiving patients, better way of giving care at inpatient wards, and substituting one thing that is, it could not be bad, but that is not satisfactory, or that is not a quality, with another that is quality, and with customer satisfaction, or patient satisfaction, including staff satisfaction. So this replacement of one, the presence one and the new one, is called a change. When we detailedly discuss about a change, the idea of signs of improvement comes in our mind. We usually define, we know the definition of science, it's knowledge attained through study or practice, and an improvement is increase in value or in excellency of quality or a condition. So when we jointly define signs of improvement, to bring about an improvement, there are values to be increased, excellences should come up. So the way we bring these excellences, the way we bring these values need a knowledge to be attained. So through the process of attaining values, through a process of excellency attaining, we get knowledges, and we attain that knowledges for a quality improvement to last as a quality improvement. We need to sustain and retain that knowledge. So science of improvement defines it with a short with this, and quality improvement is, as we define, quality improvement means the organized creation of beneficial changes. Here we need to notice the beneficial changes. There are many changes that are not beneficial. If we replace some machine or some reagents which are not producing an accurate result with other similar reagent which does not produce an accurate result, is not, it's a change basically, but it's not a beneficial change. Or if we notice a physician who is coming routinely late, and if we want to make a change, and if replaced physician also have a trend like the previous one, it's basically a change, but it's not beneficial change. So when we think of changes, they are changes that result in quality improvement, they should be a beneficial changes, which is the attainment of unprecedented level of performance. So if you are working in healthcare, we all have a performance evaluation or performance annual, quarterly, and biannual performance evaluations. And upon performance evaluation, we usually know our levels of performance, our levels of customer satisfaction, our levels of staff satisfaction, our levels of mortality rate, our levels of waiting time to consultation, our performance of emergency triage within 5 minutes, and inpatient mortality, the ICU mortalities. These all are presented in the performance with a label, and with comparing the level from the national standards, it could be with the organizational target standards. They need to be, there is a gap identification with the performance evaluation. So quality improvement is to increase the level of our performance for the next time, for the next year, for the next quarter, and these whole things are called quality improvement. For resulting in quality improvement, we need to set ambitious aims. We usually aim to something to be reached or predict something to happen. If we take an example, if our waiting time to consultation for outpatient department was 1 hour, average 1 hour, so we need, if we need a quality improvement, we have to set an aim. When we set an aim, we need to check for the national standards and the previous performance of that hospital waiting time and other references. So ambitious aims should be set for a quality improvement, we need to increase, we aim to increase or decrease our average waiting time to consultation at our outpatient department from 1 hour to 40 minutes or 35 minutes, which is a national standard. So the first thing is we need to have aim, and then we need to test. We will come over the last one. We need to test. We need to measure the change in work routines, and we need to spread best practice for rapid uptake at the larger scale to address a specific issue. This means we need to test the changes in a small scale. If we start as an outpatient within 1 OPD as a test, and if that change idea makes a difference, we need to distribute to the other OPDs. So that's the spreading best practice. If we are successful to all our OPDs, we need to spread it to the other hospitals as a benchmark and other things. And then observation, testing, and feedbacks, we will come on detail. This whole thing is are needed for quality improvement to be happen. Here, to increase the value of quality improvement, a care provider, the care we provide to our patients, we need to apply this scientific method. We already discussed the science of improvement. So scientific method is using that knowledge which helps us to bring the improvement. So for improving our quality of care, these methods are usually required. The first thing, we need to set an objectives. Setting objectives means what do we aim to improve? What is where we are now and where we want to be after some stated times, where we want to reach. Let me take the previous example. We are at 1 hour average waiting time. So our objective is to decrease from 1 hour to 35 minutes within some specified period of time. So setting objective is the first scientific method to have improved quality of care. Without objective, things will not be as considered as a quality improvement. Without stating this objective, I will work some change ideas, but I cannot monitor that that implementation or that change idea results. And the other one is hypothesis should be generated. There is a problem identified. So after the problem identification, we need to set a hypothesis or a prediction. We need to set a prediction. The aim I told you previously, we aim to decrease from 1 hour to 35 minutes is a hypothesis. It will be decreased. By the end of 3 months, from 1 hour to 35 minutes, the waiting time will be decreased. So this prediction should be stated. So at the end of the quality improvement activity, when we evaluate the improvement activity, yes, you reach your prediction. So your change ideas were good. If we didn't reach our hypothesis, no, this change idea is not good. So we need to you need to change your change idea since you did not reach your prediction. So hypothesis generating is the second scientific method which can help us in improving quality of care. The other one is experiments. Experiments should be regularly done when we identify problems, because that problems will be maybe occurring for the first time, or it could be a data fallacy or other thing. It could be the problem could be as a result of something different than we want to change. So experiments need to be done. Then after experiments, analysis should be done. Analysis is by reviewing data, by reviewing documents, by comparing results from the last year, from the previous year, by considering the condition, the geographic condition, or the rainy, it could be the increment. When we take an example, if an emergency case is increasing rapidly, and if it is a rainy season, why is that happening? Is the asphalt or the ways of around that hospital, is that slippery, that many accidents are happening, or these things need to be analyzed. And even analysis is not outside the hospital or outside organization, but also that data need to be cleared. Is that really a gap, or is that a report problem? So we need to analyze and then evaluate documentation. All reports which bring us a gap will not be accepted. So we need to evaluate documentation. So all scientific methods, with these all scientific methods, we will reach on the specific problem. So it will help us to generate a change idea that will help us improve and result in quality improvement. In doing so, we need to have a fundamental principles for a successful improvement. We need to set a principles which we need to follow. So every improvement requires a change. So the first fundamental principle for successful improvement is know why you need to improve. One person do not have who is having an improvement plan will not start by testing a change. Just started to this thing need to be changed, so I need to apply this. It will make it won't make a continual improvement. So the first principle is why you need to improve. This is the starting point of an improvement. So knowing why to improve is, as we already discussed, the objective of quality improvement. Setting objective and setting aims will be entertained in this fundamental principle. And the second one is having a way to get feedback. After applying a change, we need to have a space of feedbacks. The change you implemented is not working, or the change you implemented could be modified, because we are doing this way, that your change idea was to make us to work this way. But if we change it the way we are working, it will make more results. So we need to accept comments, any ideas from the persons which the change idea is implemented. So we need to have a way or a place of accepting feedbacks from everyone who is accepting this change and implementing. The other one, develop a change which results an improvement. There are many change ideas that comes to your mind, but we need to choose, we need to prioritize, and we need to identify which change can make the expected result, the expected improvement. So the other principle is this one. And the other one is we need to taste the change. Before any action to implement is the basic thing. Testing the change comes in 4 steps. If there is any other session we can discuss, it's almost one specific because we will plan a test including many things aspect and with a small scale testing started with a small scale. So the first principle is testing a change. When we test a change, it should be with a small scale. If we want to improve the waiting time, as already discussed, on the whole OPD, if you have 5 or 6 OPDs, when you need to start from one OPD, and if you are successful, you need to go to the other. So testing with a small scale is the other principle. Then if the test is results in a good improvement, we need to implement. Implementation is like spreading the change idea and standardization of the change idea in that organization or in that healthcare. So every improvement requires change. Unfortunately, not all changes result in improvement, as we already discussed. When we come to this, how we discussed about changes. So from where to bring these changes will be our question, our next question. So we need to have knowledge to generate ideas. The knowledge is in to bring new ideas, which one to use. We will discuss on this. The first thing is subject matter knowledge and profound knowledge. As you all know, subject matter knowledge is the basic or the routine knowledge is acquired through learning, through it could be life from our families and from any other place that is called subject matter knowledge. When we think of a doctor or a nurse, she has all her own subject matter knowledge, how to treat cases, how to treat patients, how to communicate cases, how to take vital signs, and so on. Things are called subject matter knowledge. When we come to the profound knowledge, it's vaster than the subject matter. More of thinking of more of details, detailing, and to make a change that will result in an improvement, we need to consider the impact the change will have on these 4 components. These 4 components are the lenses of the profound knowledge. So when we think of the profound knowledge, we need to see with these lenses, like we need to appreciate for the system that is appreciation of the system is there is a complex system of interaction and interdependent groups of people that are working in the organization. It could be departmental or in the unit, and these procedures and like the items, equipment is working towards achieving a common goal, then it is vital to understand the components and parts of the system. So in a gynae department, the whole team should understand what equipments are there, what materials are there, what to work, and what the physicians work, what the nurses work, and how the process and the outcomes expected from that department. So when we look at these whole details, the inputs for that department, human resource, materials, and other facilities, infrastructures, and the process of that department is going, a patient receiving to the patient discharging, this whole process, and the outputs. The outputs are discharged patients, days or transfer, and this whole pressure, appreciating this whole system, we call it a profound knowledge. And the other one is building knowledge. Building knowledge using PDCA cycle. You know what PDCA cycle are, I hope so. Plan, do, carry, act, or study, act cycle. We call it PDCA cycle or PDCA cycle. So with doing planning, by doing planning for an improvement, then cascading or entertaining or doing the plan, change idea, then studying the results. It could be by observation, it could be by experiments, or it could be by collecting data. We will study the change idea implementation results, then we will act upon the result of our study. Our study results, if our study results shows us an improvement, which is a quality which we expect or which we predict, we will accept that change idea. If it is not, or if it needs some modification, we will adopt it. And the other thing is we will adapt the last study, and it will continue with the next P. After acting, we will continue the P. So through this process, we build knowledge. Which change idea can make an improvement? Which change idea cannot make a change? These whole things are knowledge. So with a profound knowledge, we build knowledges through PDCA cycle. The other lens of profound knowledge is understanding variation. Variation is everywhere, even if we have variation in ourselves. Let me say an example of variation. If we take our body temperature in the morning, it may measure like 36.1 to 37.2 usually, but there are some different variations, like if we once measure 39.3, we have headache and other things. This is also variation. So in 1% also there is variation, and when we go to a group of people, there we need to expect more variation. So when we apply a change ideas, when we need to improve or bring a quality, we need to appreciate those variations. When we a change idea, we need to expect, I think this one is a bit blurred, but when we implement a new idea, there are only 2.5% innovators that accept our change idea immediately and implement that change idea. And we need to expect some of the early adopters, like 13.5% of our audiences to accept us. Sometimes after implementation of, after looking of the innovators, what the innovators do, and by looking at the changes that innovators brought, and those, many of them are 34 and plus 34 over 68%, like early majority and late majority. They are most of the time, and taking the highest percent, they are almost they need sometimes some longer times to accept your change idea. There are also 16% of the audiences who will not accept your idea. So we need to understand this variation upon application of our change ideas. If we are not considering these variations, our change idea will be unsuccessful. So considering this variation, we need to plan accordingly. The other part of the profound knowledge is psychology. Psychology, it means human side of change. This is basically different from new things. This is the psychology.
Doctor?
Yes. So when we come to the specific changes, QI that may, quality improvement that may seem unrealistic at first, but can be realized by the first thing, redesigning process of work. As already discussed, we appreciate our system, we appreciate our processes. So when we redesign processes of work, we can bring quality improvement that we think it could be unrealistic, but with using this change ideas, we can attain it. And the other one is reduce wastes and increase values. Wastes, it's not only infectious or other wastes. Being late or being unpunctual is one wasting of time. It could be wasting of materials. Using glove inappropriately could be a waste. So there are many wastes in our health cares. So reducing that wastes and increasing value will result in quality improvement. The other one is addressing root cause to our problems. Here, I want to discuss on the reactive and profound reactive and fundamental changes. The reactive change is when we give a change or a solution for things immediately. If an OPD chair is broken, when we will maintain it as a reactive change. When a physician is late, when we replace that physician with other physician, it's a reactive change. But what is most important for quality improvement is fundamental change. So to bring about a fundamental change, we need to address root causes to our problems. What was the reason the physician is late? Is it recurrently, is he recurrently being unpunctual? Or other detailed root cause analysis, it's almost one topic, and we need to have a root cause, and for that root cause, we need to have change idea. At that time, it becomes a fundamental change that will not happen again, and our quality improvement will be sustained. The other thing for quality improvement is by prioritizing major contributors to the problem and by generating new ideas to address existing challenges. One thing you need, I need you to, everyone to have is, if we want to bring about a quality improvement, definitely we need a new idea. unusual ideas, new ideas, unpracticed new ideas. Unless otherwise, if our ideas are where we are previously performing, that will not make the quality improvement as we wish, as we predicted. So with these four things, every improvement needs change, although not every changes is an improvement. We will go to the types of changes I already discussed. So reactive changes have low impact since we are only implementing that thing immediately to solve current solution, to have current solutions, but it's not sustainable. And it only covers a single part of the system, only the system which has immediate problem. So when we come to the fundamental change, it has high impact since it results in a continual improvement and it will result in a quality improvement. Then it will address multiple systems or parts. So if you want to decrease the waiting time, I just repeated this example since it was more exemplar. So if we take the waiting time to decrease the waiting time, just only if the medical director or a PD director informs the physicians to enter early and see the cases to rapidly, that will be a reactive change for one day or the next day. But if we need a fundamental change, we need to have the root cause, why it's 1 hour and how to decrease this. It could be the problem will be from the nursing team, the problem could be from the medical record room, the problem could be from the patient side. The patient will not be around when they are called. It could be some other reasons could be the reason of that long waiting time. So multiple system parts will be improved to bring the quality improvement. So we call it a fundamental change. When introducing a change, we need to have cautions on this, especially the tools and the 2 pointers. The more of the same sense is when you ask someone in the ward why this problem is happening, everybody will say if you add some staffs, it will be improved. If we have some equipment, these things will be improved. That's not a quality improvement. This is a reactive change. So we need to be cautious on more of the same things. So first solutions suggested are added more staff, more equipment. This cannot be a change ideas to result in quality improvement. The other is Ethiopia syndrome. This is delay testing of any change, try to find the perfect one. On the Ethiopia syndrome is we have many change ideas on hand, but we are trying to find the best, the perfect idea, and we take long time to have to get the perfect change idea. But that's not the way of the quality improvement. We have a change idea, we test it with a small scale, and if it improves, we take it as a good change idea, and if it fails, so we need to consider, look at cautiously with these change ideas. So that will affect our processes. When we come clearly how to generate new ideas, we need to look at 2 thinkings. The first is logical thinking, and the other one is lateral thinking. More logical. Usually we use them both jointly, and when generating idea, our brain follows certain patterns. So we make connection to things we know, we make connection to things we hear, we make connection to things we read, where something important, and that can be a change idea. And when connecting these four things, we can produce a solution of a change. So this normal tool pattern, what we call them logical thinking. So it comes in two forms. Logical thinking could be in two forms. One, positive logical thinking, and a negative logical thinking. Positive logical thinking, both will be important for our new idea generation. And the positive thinking is reasoning on why to make new ideas, why we need the new ideas, why the first thing we expressed in as a fundamental part of a successful improvement. In the negative is the critical thinking, finding reasons why the new idea may not work. So if we prepare ourselves with the positive and the negative ones, we will result, or we will reach on our predicted values. So both are the negatives and the positive logical thinking will help us to attain our goal. So we have many tools when we use the logical thinking. The first is brainstorming. Just brainstorming, from the word, it means using our brain to exercise, or to bring us a new idea, discussing with a group of peoples, asking someone professional or experts and other things. By doing this brainstorming, we can generate the new ideas. This brainstorming tool can be used on the whole 6 tools, can be integrated with the whole tools. The other one, benchmarking, as already discussed. If some departments or if some other organizations have a good or a quality of care on what we have gaps, we can go there and have benchmarks. So you know all what benchmark is. The other one is random entry. When we use random entry, there are these are random entry words or nouns. You can get it from the National Quality Improvement Training module. And by randomly taking the numbers or these nouns, we think over new ideas. We think over new change concepts. And if we randomly take, or let us take, one person can raise and tell me one number for the problem we raised previously, for the waiting time, when one person who can raise your hand and call one number from this 60 random words. Doc.
Okay. 43.
Huh? 43. Eyes. So we are thinking of decreasing waiting time from 1 hour to 40 minutes or 35 minutes, and randomly we take eyes and we think over it, we brainstorm it. How could eyes be related to this? Anyone who can entertain? ice melts, didn't it? So if ice melts, there is something to be changed. So for my observation, I have ideas. I will have an ideas to decrease that waiting time. So when I see ice, it will melt and it will be water. So if we take the ice again to the refrigerator, we will have an ice, we will return it back. So as I think, and there is some improvement, or there is a change idea that can be implemented, and I can improve what I predicted. ምናልባት የምፈልገውን ነገር ድጋሚ አገኘዋለሁ ሰው ተስፋ አልቆርጥም አይነት ነገር የሚለው ነው ጭንቅላቴ ውስጥ የመጣው አይሶን ሳስብና እቺኛዋን ምናልባት ታፍ ሊሆን ይችላል ኤክሰርሳይዝ እናረጋው ነው የምናገኘውና and when we come to the other the process mapping, I already discussed the process mapping. We have to sketch our processes of each services from the patient entrance to the patient exit. So with these processes, where is our gap? Where is our problem? Where is the longest time the patient is spending in the hospital? Where is the delay? So finding these things by mapping our processes of the whole system and implementing changes to these gaps by using our logical thinking can be one source of new ideas. The other one is Pareto chart. Pareto chart, as already discussed, documentations, analysis, and will result in the Pareto chart, and there will be a figure of with percentage. It could be by percentage, it could be by number. So if we take an example of neonatal days causes, we analyze the result in neonatal sepsis, neonatal jaundice, neonatal respiratory distress, and the like, and we grade them with percentage, and the highest percentage is with the neonatal sepsis and the perinatal asphyxia. So doing that, taking or generating new idea for the sepsis development in 10 days will cover all the risk if they are accounting over 60%. By solving the 60%, and by having a change idea for the 60% for the neonatal sepsis occurrence and for the PNA occurrence, I can decrease the neonatal mortality at the neonatal ICU. That's the principle of Pareto chart. And one new idea generation tool using the logical thinking. The other one is driver diagram. Here is the driver diagram. It's the reverse fishbone diagram. If you have an exposure for the fishbone diagram, it's the reverse one. So the aim and the solutions will be kept in the head. So on each thematic area, there will be a change concept. This thematic area could be facility-wise, the other one human resource-wise, client-wise, regulatory body-wise, and other thematic areas could be dotted here. Then on the change concepts, what we think to change, the broader change concepts will be written. Then on for each change concepts, there are individual and more than one change ideas. So this is one way of producing change idea. So these are not only the tools that are used on logical thinking. There are 5 whys, root cause analysis, and many others. So we have various tools and methods that can guide us in logical thinking to generate ideas for identified problems. And this is the other way of driver diagram. So primary driver, secondary driver, and lastly, the change ideas will be driven like this. Do I have time, Doctor, to have this 1 minute exercise?
Yeah,
like,
we can. Yeah, we can continue.
I'll take it as a home take message and connect these 9 dots with 4 straight lines without lifting the pen from the papers, and you can exercise there. And the concept is the lateral thinking. If you are not going out of the 4 boxes, you cannot connect these 9 dots with only 4 straight lines. So that's why I brought it here and exercised it with your own. So lateral thinking comes with this idea. We usually have change ideas, but extra, we need to have thinking of out of the box to generate new ideas. That's when we can produce a great or a new idea that can result in an improvement. These are the tools used for the lateral thinking, provocation, fishbone diagram, 6 thinking hat, change concepts, and we will see them. This is the fishbone diagram, which will help us in assessing the root cause and generating new ideas. So we will have thematic areas. So for each thematic areas, we will have detail and root causes for that specific written causes. For each causes, we can generate a new idea. So this is one part of the lateral thinking, and the other one is provocation. When we say provocation, the first is thinking reversally. What if this didn't happen? When a physician is late, sorry to say, if your physicians are there, and when physicians are there, when we think of provocation, what if the physician is not interested on doing orthopedy? What if that physician is not good to treat an outpatient cases? What if he is good at inpatient services? Like this reversal thinkings are called and exaggerate. One example, the word is almost exaggerated, but you can define it when you think of lateral thinking, we need to exaggerate things. What if perinatal asphyxia is almost daily for daily? There are 7 days of perinatal asphyxia. So the reason is something because of the mothers coming late. Exaggerating things and that on that time, change ideas will brought to our mind. Escaping is also what if I don't understand this one? What if this didn't happen? These are things provoke. These are change ideas which can be brought by provocation. If we take an example, you have no radiant warmer at your NICU, or you have one NICU, but you wishfully think, if I have 10 beds for neonatal, I may manage many neonates in my neonatal ICU. So when you wishfully think, you will search for many other possibilities. Let me tell one example and pass this one. At one hospital, they enter to the NICU and they hopefully wish that we have many beds to serve many neonates in our neonatal ICU, and they go around the rooms. And at that time, they found something which is used for water, keeping water, and they have some new ideas. Why don't we test this one and make some more beds for neonates to sleep on? So they make it, they modify it and have many beds for neonates that are not needing a radiant armor or other neonates admitted to the neonatal ICU. So wishful thinking is when we provoke something, things, new ideas will come to our mind. So that is lateral thinking. This is the random entry, and the other one is lateral thinking is using change concepts. As we already discussed, like if we want to eliminate wastes, we will go to these change concepts and eliminate things that are not used, eliminate multiple entries. We will read all these concepts, and one change idea or two or three change ideas will bring to our mind, and that change idea will be a good change idea or tested and implemented. So change concepts can be also used. You can find this on the quality improvement training manual. The last lateral thinking tool used is 6 thinking hats. For when we sit to have new ideas, we need to have this number of peoples, or one person can think over by exchanging the hats. The white hat is the information delivering. This is the fact. The neonatal mortality here is here. The neonates who get to the neonatal ICU get sepsis after 2 days. The neutral, as a neutral body, this when wearing this hat, we will be a neutral body and get informations and objectives. And when we wear the red hat, we will feel our emotions, the gut feelings, intuitions, and hunches, and produce some change ideas with these emotions. And when we wear the judgment, critics, what if, why this is happening? If this is happening, if this is happening after 2 days of admission, so there is something in our infection prevention practice. That's why. So logical thinking, logical negative. So with that thinking, we can produce new change ideas. The yellow one is brightness, sunshine, and optimism, positive, everything. Okay, they're making their face, the stars are making their face, that these are things are bad. So we need to improve that thing so we can get a change ideas. And the green one is creativity, new creative ideas, grows possibilities, and new ideas will come to our minds when we wear the green hats. And the blue one is cool agendas, processes, organize, overview, decisions, and these whole things will come when wearing the blue hat. So when using this whole 6 hats, there are different change ideas come to our mind. So we're picking those change ideas, prioritizing and testing, then implementing the base change ideas. So as a summary, To introduce change for improvement in your facility, we all need to understand the central principles of improvement. And as we already discussed, we have types of knowledge need to be combined, both the profound knowledge and deep understanding of the system, variation, building knowledge, and psychology of changes that are the profound knowledge lenses. And leaders for quality improvement should understand that there are poor systems and not poor performing peoples. Always we need to note, we need not to start with blaming peoples for the poor performance. So there is a poor system, so I need to change. These things will be the best approach for a leaders. And the other one is value difference amongst people, and how individual contribute to team should be appreciated. As we discussed, variations should be appreciated. Look at the interaction between all the parts of profound knowledge, the 4 profound knowledges, and look behind decisions and actions to find underlying fundamental assumptions. Lastly, I want you to take these 8 messages. Quality, it's producing a change that makes an improvement, successful improvement. We need to follow the scientific methods, the 5 scientific methods: know why, how, and evaluate and implement. And for a new ideas, we need to have a creativity and knowledge for improvement. We need to have profound knowledge rather than with using the 4 models. And we need to use change concepts. Usually, rather than reactive change, we need to focus on fundamental change, and we need to avoid more of the same, Ethiopia syndrome, and perfect solution to the wrong problem. And ideas for successful ideas is all lateral logical thinking. Thank you. If any question?
Thank you very much, Dr. Hewan. Yeah, there's one question in the Q&A section, so if we can address that and end today's session.
Okay, what challenge do you face? How did you come up with the solution? Can you please tell us about an idea and its application that you are proud of, that you come up with as a quality officer? How do you see our current healthcare system from quality perspective and possible media? Okay, it looks like more of personal questions, but in working as a quality officer, we have many challenges, but let me make the challenges specific to related to this topic. When I'm doing quality improvement projects, I usually go through the steps, detailed root cause analysis, and change ideas, generating change ideas, as already discussed. But one challenge was implementing testing the changes in our health cares. For testing changes, we have some, we lack something. Usually we lack something in some of the problems. And the other side, some of the problems we are facing in hospitals need more budget-wise and other concepts. We were in like Utopia syndrome. I was having Utopia syndrome, and I have 1 or 2 accidents or prolonged quality improvement durations. But after that, I passed these challenges by testing with the small scales and making myself as a tester. I have an experience of working at the medical record room for about 1 month. It's because of my quality improvement project. I was not having someone to taste that improvement idea, so I just get daily in the morning at the medical record room as a medical record room staff and tasted my change idea. Then it was a good change idea. Then I replaced someone for that change idea, and the improvement was sustaining. So this kind of solutions were provided. That you are proud of, that you come up with as a quality of, it's just more a quality or personal question. How do you see our current health care service from quality perspective? It's in a good path. I think it's in a good path, especially recently. The IHAC fourth cycle is the best thing for equality paths, because many of the gaps we have in healthcare systems were addressed in IHAC fourth cycle audit tool. So I think the Minister of Health is also working towards achieving this quality. It has a hope. I think it has a brighter hope, as I thought. And the other one, okay, the order of central principles of quality, it's not specifically within the order, but because developing change idea, really, as you said, is before the feedbacks. I just put the ideas. It's not the stepwise. It was not a stepwise, just a numbering. You are correct. After developing change ideas, then we will open for feedbacks, then we will receive and we will improve the change ideas.
Yeah. We have finished all the questions. Thank you very much, Dr. Hewan. And on behalf of Blue Health Ethiopia and all our participants, we would love to thank you in presenting such an important point of discussion. And we hope to meet you in the future with other topics as well. If you have any last remarks that you want to address, let me give you the stage one more time.
Thank you so much for inviting me this to this webinar. Since I was working on these things for a long time, and to have this session is a good opportunity for me. Thank you very much.
Thank you very much, Doctor, and good night.